Let's just jump right in. Welcome to this explainer. You know that absolute sinking feeling in the pit of your stomach when a patient winces in the chair right after you are dead certain they were fully numb? If you've been there, you are in exactly the right place. Today, we're targeting one of the most stressful scenarios in clinical practice, the super high failure rate of the standard inferior alveolar nerve block, the IANB, when you're dealing with a highly inflamed tooth. We are going to completely demystify exactly why this happens, and more importantly, we're going to arm you with a concrete, evidence-based clinical pathway to overcome it.
To get there, here is the game plan for this explainer. We're looking at the hot tooth dilemma, mechanisms of anesthetic failure, the mylohyoid factor, the stepwise escalatory protocol, and finally, definitive rescue anesthesia.
All right, part one, the hot tooth dilemma.
Symptomatic irreversible pulpitis. We all know it, we all dread it. It's the classic hot tooth. We're talking about a degenerative, inflammatory process of the pulpal tissue. It's marked by spontaneous, intense, or lingering pain to hot and cold, and biologically speaking, there is zero possibility of healing. It requires immediate endodontic intervention. But obviously, before you can treat it, you have to numb it, and that's exactly where the extreme frustration begins for both the patient sitting in the chair and the clinician holding the syringe.
Think about a normal, uninflamed tooth. You give a standard primary IANB, and you're generally looking at a solid 80 to 85% success rate. But when you're dealing with a hot tooth, that success rate absolutely craters to a dismal 15 to 30%. I mean, that is just incredibly low. So if you've been beating yourself up trying to numb these teeth, let those numbers validate your struggle. It's definitely not your technique, it's the biology literally working against you.
Which brings us to Section 2, Mechanisms of Anesthetic Failure.
So why does the IMB fail so often in these specific cases? Well, it's rarely just one thing. It's basically a perfect storm of multifactorial issues. We can break it down into three main buckets. First up, anatomical variations, things like accessory innervation or maybe a bifid mandibular nerve that your standard block completely misses. Second, we have biochemical alterations, which means changes at the cellular level, like tissue acidosis and nociceptor sensitization. And third, psychological factors. Because let's be real, extreme patient anxiety in the anticipation of pain can actually amplify how pain is perceived, even if nerve conduction is partially blocked.
But the real heavy hitter here is the biochemistry. When a tooth is highly inflamed or infected, the local environment drops in pH. It gets histologically acidic. Now, local anesthetics are weak bases, right? So in this acidic environment, those anesthetic molecules become ionized, meaning they take on a charge. And because of that charge, they physically cannot cross the lipid-rich nerve sheath. You could inject the perfect volume in the exact perfect anatomical spot, but that acidic environment essentially neutralizes your anesthetic before it can even do its job. Plus, that same inflammation activates and sensitizes the nociceptors, so it actually takes a much stronger stimulus to block those pain signals in the first place.
Moving on to Section 3, the mylohyoid factor.
We've all asked ourselves this exact clinical question. You give the block, you wait, you test the patient, and they say, yep, my lower lip is completely numb. You start your access and bam, they jump. The tooth is still feeling sharp pain. How on earth does that happen? Well, this scenario perfectly highlights why we have to look out for accessory innervation. The IAN is successfully blocked, sure, but some rogue nerve is feeding signals from that tooth straight to the brain.
Enter the mylohyoid nerve. Historically, we've thought of this guy as just a motor nerve moving the floor of the mouth. But the research tells a totally different story. It actually carries sensory collateral branches directly to the mandibular teeth, especially those first molars. And the hidden complexity here is wild. The mylohyoid might branch off unusually high in the infratemporal fossa, totally sidestepping the pull of anesthetic you just laid down for your standard INB. Or it might be literally shielded by the dense phenomandibular ligament. Oh, and get this, some of its fibers can even cross directly over the midline to provide contralateral innervation. Basically, if you aren't accounting for the mylohyoid nerve, your block is probably going to fail.
All right, Section 4, the stepwise escalatory protocol.
This right here is the core of the explainer. It's an evidence-based sequential playbook designed to methodically conquer the hot tooth. Step 1, administer your primary INB. Then, and this is absolutely crucial, you must wait 5 to 7 minutes and verify lip numbness. Seriously, do not rush this part. If the lip isn't numb, you miss the primary target. But if the lip is numb and the tooth is still hot, immediately move to Step 2, escalate. This means throwing in a targeted buccal infiltration or trying an alternative block like a Gaugates or an Akinoshi. Now, if the pain still persists when entering the dentin, you move confidently to step 3, the intraligamentary or PDL injection.
Now, when you do escalate to a buccal infiltration in step 2, your specific choice of drug formulation is huge. A 4% articaine buccal infiltration boasts an awesome 84% success rate as a supplemental injection. Why? Because articaine has incredible bone penetration properties. Compare that to a standard 2% lidocaine buccal infiltration, it just struggles to punch through that dense mandibular cortical bone, giving you a significantly lower success rate. So swapping an articaine for those buccal infiltrations, that is a crucial, absolute game changer of a clinical strategy.
Okay, so let's say you did the block, you did the articaine infiltration, and the tooth is still screaming. Time for step 3, the PDL injection. We really need to reframe how we view this one. It is not some desperate last resort. It's a proven, authoritative third step. You're using high pressure to literally force the anesthetic down through the periodontal ligament space directly into the cancellous medullary bone around the tooth apex. And it works brilliantly. Success rates jump up to about 93% upon reinjection. It requires precision, though. You only need to administer 0.2 to 0.6 milliliters per root using really firm, high pressure. And the best part? The onset is lightning fast, usually kicking in within 1 to 2 minutes.
Finally, Section 5, Definitive Rescue Anesthesia.
When all else fails and you manage to get that access into the pulp chamber, use the ultimate rescue technique, the intrapulpal injection. The mechanics here are absolutely fascinating. As the literature states, the intrapulpal injection achieves anesthesia as a result of pressure, not as a result of the local anesthetic solution. Let that sink in for a second. You are no longer relying on the chemical blockade of the drug. This definitive technique relies entirely on firm, unyielding back pressure. You literally have to wedge that needle tightly into the canal orifice. If the fluid just washes back out, it's not going to work. The pressure itself is what forces the anesthesia, meaning you could practically use sterile saline and it would still be effective as long as you maintain that back pressure. So we've traced the tricky anatomy, we've broken down the nasty biochemistry, and we've walked through the step-by-step clinical pathway. Now I want to leave you with this final thought. Will you continue to rely on a single, frequently failing block, leaving both you and your patients completely frustrated? Or are you ready to abandon that reliance and integrate this methodical, stepwise escalatory protocol into your daily practice? By respecting the underlying biology and systematically escalating from the INB to the articaine infiltration to the PDL and finally to the intrapulpal injection, you can definitively conquer the hot tooth. Thanks so much for joining me on this explainer, and I'll catch you in the next one.